To my channel. In this video I will discuss hemophilia. So hemophilia is an X-linked recessive bleeding disorder. It is a bleeding disorder that is X-linked recessive. It is caused by a deficiency of clotting factor 8 that is called hemophilia type A, or it may be hemophilia type B if there is deficiency of clotting factor 9. So clotting factor 8 is when deficient, it is hemophilia A. When 9 is deficient, then it is hemophilia B. Hemophilia is slightly more common, 1 in 5,000 male births. Why hemophilia B is slightly less common? It is 1 in 25,000 male births. Why male births? Because it is X-linked recessive. Pathophysiology. When there is deficiency in the intrinsic pathway factors, it leads to impaired thrombin generation. And when there is impaired thrombin generation, then fibrin clot formation is also defective, leads to bleeding. There is a problem in the intrinsic pathway due to deficiency of these factors. What are the types? As I have told you, hemophilia A due to factor 8 deficiency. It is more common, 80 to 85%. And hemophilia B, that is also known as Christmas disease. It is due to factor 9 deficiency. It is almost 15 to 20% of the cases. What are the features? When there is severe deficiency, then it leads to spontaneous bleeding. And when there is mild to moderate deficiency, then it leads to bleeding that is triggered. For example, during surgery or trauma. So, the bleeding can be recurrent hemarthrosis, that is bleeding into the knee, ankle or elbow joints, and it is mostly seen in severe hemophilia A. Muscle hematomas, prolonged bleeding after trauma or surgery. It is seen in both mild to moderate or severe hemophilia A. Then intracranial hemorrhage, serious life-threatening bleeding can also be seen. There are no petechia because platelet function is normal, so petechia or mucocutaneous bleed is not seen. It may be severe when there is less than 1% of factor 8. It leads to spontaneous bleeds, as I have told you. It may be moderate when the factor 8 levels are 1 to 5% of normal and bleeding with minor trauma is seen. While it may be mild when the factor 8 activity is 5 to 40% and bleeding with major trauma or surgery is seen, while spontaneous bleeding in these two is rare. Investigations. First one is when you do APTT. APTT is prolonged because intrinsic pathway is affected, while PT and bleeding time is due to platelets. So platelets are normal, so bleeding time and PT is normal. Specific factor 8 or factor 9 assay confirm the diagnosis and also help us detection of the levels of factor 8. Genetic testing is done for carrier detection and prenatal diagnosis. Complications. First one is chronic arthropathy due to recurrent hemarthrosis, inhibitor development because the patients are receiving continuously factor 8 infusions and therefore antibodies form against these factor 8 and factor 9, especially factor 8. Transfusion related infections historical. For example, if the infusion is contaminated, then it can transmit hepatitis C virus, hepatitis B virus and HIV. That is seen in other transfusions also. Management. Factor replacement therapy, that is factor 8 or factor 9 concentrate, is the main goal. Prophylaxis in severe cases is required. For example, in patients who have severe, that is less than 1% factor 8 activity, therefore these patients should receive prophylactic infusions of factor 8, and this is given twice weekly, and mostly it is done after 4 years of life. Next one is desmopressin, DDAVP. DDAVP is given in mild hemophilia A because DDAVP causes release of factor 8, from the endothelium. Therefore, DDAVP is used in mild hemophilia A. Antifibrinolytics for bleeding. For example, tranexamic acid, aminocaproic acid can be given for bleeding, and you should avoid NSAIDs and intramuscular injections because intramuscular injections lead to hematoma formation in the muscle. Gene therapy is an emerging treatment for hemophilia A and B both.